Hello, everyone. Thanks for joining us today for a webinar to help you understand the latest in COVID-19 telehealth regulations. We are aware of any audio issues, so we apologize if there are some widespread network traffic issues. So please bear with us. We will have a brief presentation followed by the Q&A. So to ask a question, you can type that into the questions box on your screen. In the box at the bottom of your screen, you can download a copy of today's slides. We are recording this webinar, and it will be posted on our COVID-19 resource page, and we'll have a link for you to that page at the end of the webinar. With us today are Patty Telgener, Vice President of Reimbursement with Emerson Consultants and ADCES's reimbursement expert. And from ADCES, we have Leslie Kolb, Chief Science and Practice Officer, Sasha Ullman, Director of Diabetes Education and Prevention Programs, Kate Thomas, Director of Advocacy, and Joanne Brinker, Director of Practice and Content Development. So I will throw it over to Joanne right now.
Thanks, Megan. So the first thing I wanted to cover today is we did have a variety of questions last week about where to actually find information about best practices in engaging people virtually using telehealth. So I did want to just make sure people were aware that we do have telehealth resources at ADCES, and the link is there on the slides so that when you refer back to the slides, it can be easily accessed. But what's important here is that we had a variety of members who were willing to send us some short videos about some of those best practices. So you'll find those there. And then also, you'll see additional resources to support your work in implementing telehealth programs, some of the current literature around the effectiveness of telehealth, and some additional literature as well. So next I'm going to turn it over to Patty just to talk a little bit about these links about private payers in different states.
Thank you, Joanne, and hopefully I sound okay. So we can kind of quickly go through the next. I think we have like 5 or 6 slides, and just want to let everyone know, since last week on the Q&A, we have updated links, or we've added payers that have updated or created policies specific to kind of the crisis here with COVID-19. So it is recommended that you review these links, look at them for your specific payers, and make sure you understand kind of how payers are adapting. For example, many payers are kind of mirroring CMS, and they may be waiving copays, they may be waiving prior authorizations. There are some commercial payers as well as CMS that have some prepayment initiatives, again, trying to help with the cash flow during this time, especially when elective or non-COVID procedures are not happening. So again, every payer, as kind of expected, is responding differently. So we really wanted to provide that direct link to those payers. Thank you, Joanne.
Patty, thank you so much for that overview. Next, I'm going to turn it over to Kate, and she's going to talk a little bit about the CMS telehealth guidance to FQHCs and rural health centers.
Thanks, Joanne. Hello, everyone. I know that we've been waiting for CMS guidance specific to FQHCs and RHCs and billing and providing telehealth services. And I'm happy to report that we do have an update. CMS did release guidance last Friday that kind of gave us those missing details that we needed. So backing up a little bit, the CARES Act was passed by Congress back on March 27th. This piece of legislation gave FQHCs and RHCs the authority to start to bill for telehealth services in their facilities. And so the missing piece of that was we were waiting for CMS to issue some guidance in terms of what the specifics of that would look like. So we have that guidance. I've included a link to it in the slide, and I think I would encourage anybody that's in an FQHC or an RHC to really take a look at that, because I'm going to cover some high-level information from that guidance, but there are specific billing considerations that you might want to take a look at and share with your billing department. So some good news. We know that services can be provided by any healthcare practitioner working for an RHC or FQHC within their scope of practice. Now, I want to be clear here, this guidance applies only for RHCs and FQHCs. But a little bit of editorializing on my part, I think this is a good indicator that CMS is taking the provider issues pretty seriously, and I'm hoping that we'll see some expanded guidance coming from CMS very soon that addresses the RN and pharmacist issue, as well as some of the other issues that providers like occupational therapists, physical therapists, speech-language pathologists are facing on the telehealth side as well. So going back to the FQHC issue, we believe that this is any healthcare practitioner working for the RHC or FQHC within their scope of practice. So another point of clarification, healthcare practitioners can provide telehealth services from any location. This includes the provider's home, and they can provide that to a patient in the patient's home. As we know, under normal circumstances, accredited, recognized DSMT programs in FQHCs are reimbursed for one-on-one DSMT visits using GO 108. So this service can now be provided via telehealth during the public health emergency. And Patty's words are echoing in my brain right now. Patty really provides a good perspective when she says, you know, we're able to do what we were able to do before the public health emergency. So try to keep that in mind. The only difference is this telehealth component. So I think it's an important point to take into consideration. So we're not expanding all services, but we know that GO 108 is already on the list for FQHCs, so we have identified that as something that can be billed via telehealth at this time. And remember, we've gone over this quite a few times, but CMS defines telehealth as real-time audio-video communication. And we know that the phone-only, the audio-only component is very important, and it's one of our advocacy points, but at this time, it's still that real-time audio-video communication. So there are a few specifics, and again, I would encourage you to take another look at that guidance document. But CMS has provided some guidance for services furnished via telehealth in the FQHC or RHC between January 27th and June 30th. Those should be billed with modifier 95 to show that's real-time interactive audio and video telecommunications. Please include that on the claim. And then for telehealth services furnished between July 1st and the end of the public health emergency, they're asking you to use G2025 to identify that services were furnished via telehealth, and that's going to help them set the payment rates. Again, these changes only apply to FQHCs and RHCs. And I did find this YouTube video from the Center for Connected Health Policy. That's one of the websites that we've highly recommended throughout this whole telehealth process as having some great information, state data, resources for providers. They've done a YouTube video discussing some of these FQHC and RHC changes that I think might be of interest to people who are really looking to dive a little bit more into this. So again, these changes only apply to FQHCs and RHCs, but I think it's a strong indication that CMS is taking some of our advocacy efforts into consideration in their decision making. So I'll turn that over to you, Joanne.
Thanks, Kate. So we had a couple of questions both last week and this week that we're going to put up here for Patty. The first one is, can you bill telehealth for DSMT and MNT under a hospital facility NPI?
Sure. Hi, and this is Patty. I know this question kind of has been asked kind of a multitude of ways, so I'm going to kind of answer it from a high-level perspective. The form that you bill under for DSMT or MNT has not changed. DSMT and MNT remained being paid under the physician fee schedule. However, one thing that has been clearly stated by CMS since the relaxation and changes under telehealth, CMS has currently been very clear in their open door calls that telehealth cannot currently be billed under the UB04. All of those calls, that question comes up. CMS has heard that question. That may change, but today telehealth cannot be billed under the UB04.
Thank you, Patty. And then the other one for you is, does the provider have to specify telehealth on the DSMT order?
And again, we have not seen any change that would require that a provider specify telehealth on a referral. Patient obviously still needs to meet medical necessity. We encourage you to document in your chart that this service was provided kind of during the COVID-19, so you have that as record. But again, if you have an active referral, we have not seen any requirement that would say that you have to go back and have that provider say this must be done via telehealth. So we do not feel that that is required.
Thank you, Patty. Just a couple other slides to share for you to go back to as references. We have the link to the Medicare guidance on telehealth, the Center for Connected Health Policy reference sheet, which Kate also talked about earlier, the YouTube video, but then here's also the reference sheet, HIPAA guidance, the Academy of Nutrition and Dietetic Resources are also here. We also have the Center for Connected Health interactive site map, link to Medicaid resources, and then state Medicaid waiver list is also here as well. So lastly, before we jump into Q&A, I would like Kate to talk a little bit about our call to action.
So I want to first off start off by giving a really big thank you to all of you who have jumped to the call to action and have submitted letters to CMS through our Legislative Action Center. We've had close to 500 letters sent as of today, and I want to encourage you to share this link and have your patients or clients or family members, colleagues send letters as well. The text can be edited to fit a message that works best for you. I did want to note this letter is specifically going to CMS because Congress has already given CMS the authority to make some of these changes, so we don't feel like we need to engage legislators specifically on this, so we're directing all of the letters to Medicare. I know many of you have expressed interest in looping in your legislators on this, and we encourage you to do so. We've already had a strong response from some of our congressional partners that they want to help support this, and we believe there'll be a sign-on letter where members of Congress will send a letter to CMS asking them to act on some of these issues, but just reinforcing that this is going to specifically address the 1135 waiver issue, and so that's why we've targeted our advocacy effort in that way. And then also wanted to note that we've had a number of our coalition partners also stand up to engage on this issue. The Diabetes Advocacy Alliance has drafted a letter going to our congressional partners and to CMS addressing some of these broader diabetes-related issues that have come up during the public health emergency, and so we're really trying to leverage all of our partners, our advocates, and our network to really make this happen. So thank you for your efforts, and I would encourage you to continue to take action.
Kate, thank you so much. All right, so now let's jump into some of the questions that we've had from today. The first one is for you, Patty. I need to know which form billing should use, 1500 form or the UB04 form that we have always used, excuse me, using the MPI number of our facility as we are certified under. My billing is looking to me, and I cannot get straight answers from anyone for DSMT without an MD at our center.
And again, I'll answer that kind of tied to my previous answer that the form that you bill under has not changed. DSMT remains paid under the physician fee schedule. So however, today, while most, if not all, services are being provided via telehealth, CMS has clarified that a telehealth cannot be billed under that UB04. So if a hospital-based program is billing under UB04, today Medicare has been pretty clear that telehealth is not allowed on the UB04. Does that answer the question?
Thank you, Patty. We'll look to the questions, just to make sure.
Okay.
In the meantime, let's go to Sasha. So Sasha, if providing group classes virtually, what is the best way to collect the required sign-in sheet information for Medicare?
Okay, so, and I'm going to have Patty listen in on this just to make sure I've got this right in case you can correct me if I'm wrong. But documenting that your participants have arrived, for example, when they, if they're able to check in via the EMR, if you're able to arrive them or check them in via the EMR, that they've attended the session, that they're there, that should count. They don't have to physically sign in, but also your documentation, the participant attended, and your notes, your chart notes on that patient also document that they're there. Patty, do you have anything else to add about the sign-in sheet?
You know what, I don't. I would just say the same. Just make sure that you are documenting the time-based and all of that in the chart.
Okay, perfect. Thank you, Patty. All right, so then this next one is for Kate. While the PHE is in effect, how do we identify what patients fit into a rural health center or an FQHC? We have an ADA-recognized rural health center program. I'm wondering if we'll be able to use that route to be able to provide telehealth GO 108 to additional people.
Yeah, that's a good question, and something I want to be careful in answering. I think this is probably getting into territory where you would really need to speak to your FQHC administrative staff and others just to make sure. FQHC clients are typically people who are low income, uninsured, with limited access to healthcare services, so I would think that all of the criteria would need to be met. I don't know that you could necessarily bring in people outside the FQHC to be seen in an FQHC, but I would have to look into that a little bit further. But as Patty always says, if you couldn't do it before the public health emergency, you wouldn't do it now. So just really being careful that we're following guidelines. But I'll take another look at that question and see if we can provide some clarification.
Perfect. Thank you, Kate. And then Patty, one for you. Can you confirm which documentation components are needed for a complete telehealth claim? I'm assuming it would include patient consent for telehealth method of audiovisual and the location of the provider/patient.
Sure. And again, I always recommend over-documenting is better than under-documenting. So yes, so making sure that you have at least patient consent documented. Document that if this is truly the telehealth, that you've used both audio and visual. It is helpful. The patient obviously would be in the home, but it can also document if you and the provider are in your home. And then exactly the time that was spent with that patient. And then the education and the material that was covered. Also would not hurt to just add in the documentation and what are the next steps. So if you're going to be having a follow-up telehealth, again, making sure that your documentation under these times is as comprehensive as possible.
All right, Patty, one more for you that's a clarifying question. If it cannot be billed under UB04, then not only is that a change in form, but also we are certified to bill Medicare under hospitals NPI and 1500 form, you must use the RD's NPI. We've been told that we must use the NPI number we are certified under. Can you clarify?
So again, you do bill under the MPI of the sponsor of the program. That has not changed. What has kind of created some confusion, or I think some concern, is that for those billing on a UB04 under the hospital MPI, that was fine up until now trying to do everything by telehealth. So CMS, and this is not just specific to DSMT or MMT. This is the same thing as PT and OT in other services that are trying to build telehealth under a UB04. CMS has not yet changed that requirement.
Okay, thank you, Patty. This next one is for Sasha. Has ADCES asked Medicare if telehealth billing under UB04 will possibly change since many of our programs will be unable to bill or provide service?
Yes, yes. I can say we have reached out to CMS and we're asking about that. And as Kate and Patty have mentioned, this issue has come up on many of the calls that they're on as well. So we're hoping that they're going to address it, but we don't have any word yet.
Okay.
This is Kate. Can I jump in, Joanne, too?
Yeah.
Just to echo what Sasha and Patty had said, this has come up consistently across all provider types on every single CMS call that we've participated on in the past 3 or 4 weeks. This is a mega issue that CMS has identified as a mega issue, and so we're hopeful that they're going to take action on this soon. But please know that we are hearing the issues that it's causing for you, and we are communicating that to CMS, and we have the benefit of speaking from a collective voice from the larger provider community. This is a very big issue for CMS, so we are really trying to prioritize action on this.
Thank you, Kate. All right, so I think that wraps up our time for today. I'm going to turn it over to Megan to wrap up for us, and I look forward to having many of you join us again next week when we do updates and more live Q&A.
Great. Thank you all so much. Again, this webinar was recorded, and we will post it on our COVID-19 resource page, which I have the link to in the web links box that you see on the screen. And I've also added a link here to our ADCES Connect discussion thread, so you can check that out as well. And again, you can download today's slides on the screen there. And we'll leave the webinar room open for a bit to make sure you have the ability to download those slides and check out those links. And we will have another Q&A webinar next Tuesday at the same time on April 28th. So make sure you come back and check out any updates that we have for you then. So thank you, everyone. This concludes today's presentation.